Good morning. I would like to thank Professor John Tam and the organizing committee for the invitation to take part in this World Influenza Congress. The topic assigned to me is the spectrum of clinical presentations of SARS-CoV-2 infection in comparisons with influenza. So I will briefly review the epidemiology between the two infections, viral kinetics and transmission, and also go through the clinical symptom signs and spectrum. Now, although the two viruses are very different in the structures and genome organization, the transmission route is actually quite similar. So mainly through inhalation of respiratory droplets, contact with fomites, and also through opportunistic airborne transmission. Comparing pandemic H1N1 2009 versus COVID-19, about 80% of the cases of COVID are labeled as mild or asymptomatic. The mortality rate estimated by the authors earlier was 2.7, but according to the latest figure from the WHO, globally it is around 1%. For the seasonal influenza virus, it is a lot lower. So in the previous week, globally, there was actually a reduction in new cases by about 28%. And there was also reduction in the new fatal cases in the last 7 days compared to the previous week by 22%. Currently in Hong Kong, we are actually in the 6th wave, mainly due to BA.5. In the 5th wave, we had a big 5th wave, mainly due to BA.2.2. And recently, you can see that the moving case fatality rate actually is getting lower. And the current wave due to BA.5 started since May 2022. And the case fatality rate is close to 0.1. In the 5th wave, when we had the big wave due to BA.2.2, we actually built up hybrid immunity due to about 70% of the population having been infected during March and April by BA.2.2. And also there has been high vaccination rates in recent months. And we also use oral antiviral early for the mild cases. Now, in contrast, we have seen very little influenza activity since March 2020. Because of the outbreak of the COVID-19, we have actually very tight social distancing measures, and everybody wears masks in the public areas with very good hand hygiene. So the last case that I encountered at my hospital was actually February 2020, and we have not seen a case yet. The case fatality rate of seasonal influenza in Hong Kong was around 0.1% in previous years. So this is the viral kinetics data actually studied by Professor Malik Piaris from the data in Guangzhou. And this is nasal swab, throat swab, and combined nasal and throat swab. And you can see the pattern, early peaking and then decline, is actually quite similar to that of seasonal influenza. Although the seasonal flu tend to peak on about day 2, for SARS-CoV-2, peaking tend to occur in the first few days, about the 2 to 4 days peaking and then decline. So the pattern is actually quite similar to that of influenza. Now, to diagnose influenza and also SARS-CoV-2, of course, nowadays we have a multiplex PCR, and we also rely on rapid antigen tests to get the quick results. In terms of outpatient treatment for influenza, we have nasal, and so we have an NAI or baloxavir, and this would be given within 2 days of symptom onset, if possible. For the treatment of SARS-CoV-2, there are actually more options. Within 10 days of symptom onset, some patients with high risk may receive monoclonal antibody, and other high-risk patients within 5 days of symptom onset may also receive oral antiviral, molnupiravir or Paxlovid. The time course to severe disease is shorter for influenza in general. For SARS-CoV-2, we tend to see deterioration to more severe disease around week 2 of the clinical course after onset. And in the pediatric patients, sometimes they also encounter multi-system inflammatory syndrome, which may occur several weeks after initial recovery. Or some of the patients actually may be even asymptomatic to begin with, and they still may develop multi-system inflammatory syndrome. So this curve basically represents the initial phase, the viral replication phase, and then followed by the inflammatory response. So for SARS-CoV-2, we tend to see patients deteriorating in the second week of the clinical course. In terms of the symptoms and signs, fever is actually common to both. For headache, it appears to be more common for seasonal flu. Runny nose also more common for seasonal flu. But for the olfactory and taste disturbance, it is actually more marked for SARS-CoV-2. Cough is similar for the two conditions. They also have sputum production, but it is a bit more in seasonal flu. Sore throat is also quite marked for both conditions. Breathing difficulty can occur in both conditions, and sometimes patients with SARS-CoV-2, when they progress to more severe disease, they also complain of breathing difficulty. GI symptoms is also present in both conditions, appear to be more common for seasonal flu, and they also experience myalgia and fatigue. In terms of the potential complications, both conditions can lead to high fever, and some of them actually also develop laryngotracheal bronchitis. Not only in children, we have also encountered some adults having stridor. And of course, some patients may develop pneumonia, and some may even have the acute cardiac injury or renal failure, sepsis, or even death. This is data from a study in the US of the children. They look at the symptoms and comparing the COVID-19 versus influenza A and influenza B. In this study, more pediatric patients with COVID-19 than seasonal flu actually reported fever, diarrhea or vomiting, headache, body ache or chest pain at the time of diagnosis. In the same study, in this cohort of 315 children with COVID-19 versus more than 1,400 children with seasonal flu, there were actually no significant differences in terms of the rates of hospitalization, ICU admission, the need for mechanical ventilation between the two groups. Now, this slide compares influenza versus SARS-CoV-2. Both conditions actually have some patients with no symptoms. So it may occur in influenza between 14 to 50%. For SARS-CoV-2, around 20%, it may be higher in some settings. The incubation period is shorter for influenza A and a bit longer for SARS-CoV-2. For the original Wuhan strain, it was about 5 days. But then with the recent variants, the incubation period has become shorter. For example, around 3 days for Omicron. The serial interval is shorter for influenza compared to SARS-CoV-2, and the basic reproduction number is also lower for influenza compared to SARS-CoV-2. In terms of prevention, of course, both conditions now have vaccines. For SARS-CoV-2, there are also options of monoclonal antibody for those who have very severe immunocompromised condition, not expected to respond to COVID-19 vaccination. Now, for the symptoms of uncomplicated illness, they are actually quite similar. So with abrupt onset of upper respiratory symptoms, fever, myalgia, some GI symptoms, etc. However, taste disturbance and smell disturbance and chewing-like lesions of hands and toes are actually more typical of COVID-19. So this is recent data published by a group from Beijing comparing the different variants. So you can see that the incubation period for Alpha was longer at 5 days, and then Beta 4.5, Delta 4.4, and more recent variant, Omicron, 3.4 days. So the results suggest that with the evolution of mutant strains, the incubation period of COVID-19 decreased gradually from Alpha variant to the Omicron variant. Now, pre-symptomatic transmission can occur in SARS-CoV-2. So this is data based on nursing home outbreak in the USA. And you can see that the elderly subjects, even before they developed symptoms, when they were actually tested for the respiratory tract specimens, and even up to about 6 days before symptom onset, they could have actually culture positive virus. So pre-symptomatic SARS-CoV-2 infection and transmission can actually occur. And likewise, in influenza, asymptomatic or people with little symptoms can also transmit the infection. So you can see the duration of the viral load, which is shorter for those who have few symptoms or no symptoms compared to those who have acute respiratory infections symptoms. And the mean levels of influenza viral RNA shedding in asymptomatic and polysymptomatic cases were also about 1 to 2 lower compared to the symptomatic cases. And the presence of influenza viral shedding in patients with influenza who have very few or no symptoms reflects their potential for transmitting the virus to close contacts. This is a diagram showing the extrapulmonary manifestations of COVID-19. Now, of note, thromboembolism and skin conditions are actually more unique to COVID-19. So this is the data showing you the 6 patterns, the skin patterns of patients with COVID-19 who may develop these skin lesions. So it can be urticarial rash, can also be erythematous papules, can also be due to exanthem and chewing like acro pattern, livedo reticularis, and also purpura type of pattern. And a group from Italy actually studied the patients with COVID-19 in relation to the skin manifestations. And they have noticed that the chilblain-like acro pattern was significantly associated with a younger age. And after adjusting for age, it was actually associated with less severe COVID-19. However, the median duration of chilblain-like lesions was actually a lot longer compared to that of other cutaneous manifestations. So this table basically look at the persons at increased risk of influenza complications. So older age or younger age, people who have chronic illness, pregnancy, people living in long-term care facilities, certain ethnic groups. And basically, these are also similar risk factor to developing severe COVID complications. So the risk factors for both are actually largely similar. In terms of the severe complications, as I mentioned before, coagulopathy, especially thrombosis, multi-inflammatory syndrome in children and adults, and post-COVID conditions like the long COVID, they are actually more specific for SARS-CoV-2 infections. In terms of developing co-infections, community-acquired bacterial pneumonia appear more common in hospitalized patients with influenza. Invasive fungal infection is generally uncommon, but more common in people who are immunocompromised and given steroid when they develop severe influenza. The community-acquired invasive bacterial or fungal co-infections are actually quite uncommon in patients hospitalized for COVID, but the frequency may vary. So this is a paper from Hong Kong comparing the severity of SARS-CoV-2 BA.2 infections in unvaccinated hospitalized children compared against influenza and para-influenza. So the patient with COVID was a bit younger compared to influenza. And at a glance, you can see that the patient with SARS-CoV-2 due to Omicron appear, more of them actually have seizures and also croup. And then when they look at the relative risk of complications for Omicron BA.2 comparison to flu and paraflu, you can see that the hospitalized children who had no past COVID-19 or vaccination, Omicron BA.2 was not mild, and Omicron BA.2 appeared to be more neuropathogenic, causing more seizures and breakthrough seizures, mainly seizures with and plus or minus fever. And also it targeted the upper airways more than influenza virus. So more people with SARS-CoV-2 actually develop croup compared to those with seasonal influenza. Now, the multi-system inflammatory syndrome can also occur, especially in the pediatric population. So this was a 10-year-old Russian boy with COVID-19 diagnosed on the 6th of June, 2020 on arrival at Hong Kong airport from Russia. And then 16 days after discharge from the Princess Margaret Hospital, he returned with 2 days of high fever and right-sided cervical tender lymph node. And the nasopharyngeal swab PCR was negative. The fever and lymphadenitis actually persisted for 5 days, and he also developed bilateral non-purulent conjunctivitis with perilimbic sparing, erythematous cracked lips, strawberry tongue, and blanchable erythema over the trunk. And the serial blood test shows mild thrombocytopenia and raised ESR, CRP, LDH, ferritin, high sensitivity, troponin-1, N-terminal BNP, and interleukin 6, IL-6. So he was actually treated with IVIG with good response. So this actually occurred more than 2 weeks after the initial discharge from the hospital. So thrombosis is also another complication more unique to SARS-CoV-2 infection. So this paper came from France, involving 2 ICUs, and they had quite a number of patients having pulmonary embolism despite receiving anticoagulations. And there were also quite a lot of patients receiving continuous renal replacement therapy, and yet they experienced circuit clotting. And 3 of them also had thrombotic occlusion of the centrifugal pump supported by ECMO. So despite anticoagulation, a high number of patients with ARDS due to COVID-19 actually developed life-threatening thrombotic complications. And the authors actually recommend higher anticoagulation targets than in usually critically ill patients, should therefore be suggested. Long COVID is also unique. This is a very good study conducted in the Netherlands, involving a large number of patients with COVID. And they also have a control group. They actually fill in the questionnaires 24 times between March 2020 and August 2021. So there were persistent symptoms in the COVID positive participants and about 90 to 150 days after the initial diagnosis. And these symptoms include chest pain, difficulty breathing, pain on breathing, painful muscles, taste and smell disturbance, tingling extremities, a lump in the throat, feeling hot and cold, heavy arms and legs, and general malaise. Now, when they actually compare to the control group, about 1 in 8 patients with COVID-19 actually have long COVID, okay? So they need to take into account the rate of the COVID negative control who also have the same symptoms. So basically about 1 in 8 COVID-19 patients may develop long COVID symptoms. And finally, I would like to talk about this rebound of SARS-CoV-2 infection after Paxlovid treatment. So this is a very interesting report published in the New England Journal by a group in the US. So they have 3 patients with documented infection on sequencing, plus another 10 presumptive cases of rebound viral replications. And the age was between 29 to 71, median 63. So the blue part represents the time that they received Paxlovid. The red areas represent the time that they actually have symptoms. So they became symptom-free for a few days, and then they developed symptoms again. Now, all these patients actually were fully vaccinated and had received at least 1 dose of mRNA booster about 6 to 7 months before diagnosis. None of them had any immunocompromised conditions, and all recover without additional antiviral treatment. And the rebound results on the RAT became strongly positive on days 9 to day 15 and remained positive for 2 to 7 days, and then turned negative as late as day 22. And 2 patients may have transmitted SARS-CoV-2 infection to their close contact during the rebound period. So this is quite interesting, and rebound with symptoms occur in quite a lot of patients with the Paxlovid treatment initially. Another report that came out in the same issue showed that the rebound can also occur in patients who did not receive Paxlovid. So this is quite interesting. So is it the natural history of the infection, or is it related to Paxlovid? We need to have more information. The results regarding viral load rebound were quite similar in the Paxlovid group compared to the control groups. And there were no deaths observed in either group with rebound. So in summary, there has been decline in new COVID-19 cases with decline in new fatal cases in the previous weeks. And there has been little influenza activity in countries and cities such as Hong Kong with tight social distancing measures. The viral kinetics of SARS-CoV-2 resembles that of influenza. Asymptomatic and pre-symptomatic transmission may occur, and both conditions have quite similar upper respiratory tract symptoms and some systemic symptoms. However, there are some features unique to COVID-19. Patients may have longer taste and smell disturbances. They have some skin manifestations, higher risk of thrombotic events, and multi-system inflammatory diseases, especially involving children, and long COVID. The rebound of COVID with and without Paxlovid, we need to have more data. Thank you for your kind attention.